Perfect. Thank you so much. So welcome to today's Teach Educational Round session. The topic is the STOP program, Client-Centered Care, and our presenter is Dr. Peter Selby. If you are interested in obtaining a letter of completion for today's webinar, you must have completed the webinar pre-learning assessment and registration form. You must sign in to view the live webinar using your first and last name so that we can track you. And following the session, you will receive the link to the post-learning assessment and evaluation form. If you have signed in as a group or you did not sign in with your first and last name, please be sure to email teach@camh.ca, the email's on the side there, immediately following the webinar. These webinars are being live tweeted. Follow the CAMH Nicotine Dependent Services on Twitter at @PSQuitSmoking. To follow the live tweeting or to post your questions or comments, use the following hashtag #TeachWebinar. Now, today's faculty presenter, Dr. Peter Selby, is the Director of Medical Education and Clinician Scientist at the Center for Addiction and Mental Health. He is also professor in the Departments of Family and Community Medicine, Psychiatry, and Dalai Lama School of Public Health at U of T. He's also a clinical scientist at the Department of Family and Community Medicine. I'll let you all read the rest of the biography later on. Disclosures. Dr. Selby's disclosures. The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario Ministry of Health and Long-Term Care. Contents of the slides are primarily based on evidence-based guidelines from the following 3 sources. These materials, as well as a verbal presentation and any discussion, set out only general principles and approaches to assessment and do not replace the need for individualized clinical assessment and treatment plans. Now, before I hand it off to Dr. Selby, I just have a couple of polling questions here just to get a sense of our audience today. So the first question here is, what region does your organization serve? Okay, I'm going to close the poll now. So it looks like the majority of you are coming from the GTA or Eastern area. For those of you working from out of province, if you could please type into the chat box just to get us a sense of where you're coming from. The next question is, what is your current discipline? Now the list is very large, so be sure to scroll down. Okay, I'll close the poll now. Looks like about 28% are registered nurses. And the final poll is the type of organization you work for. Okay, super. So it looks like about 28% are from family health teams. So without further ado, I'm going to hand it off to Dr. Selby.
Thank you. Thank you, Tanya. Welcome all, and thank you so much. Sorry, my voice is a bit off, but I'm going to try and speak loudly. Periodically, you'll see me sipping my little cup of tea. And anyway, so today, although the STOP program has sort of now currently we've crossed 170,000 smokers in Ontario who we've helped, which wouldn't have been possible without your hard work within all the settings that participate. You know, roughly we are helping about 25 to 26,000 smokers annually, and that again is limited by the amount of funding we get to be able to help you help your patients. And we have a waiting list of sites wanting to participate. But having said that, today we are going to, you know, as part of this program, you may or may not be getting questions from your patients about other pharmacotherapies, other ways in which they want to quit. The program is quite mature. There are smokers coming back for a redo or a retry. And we know from our STOP program and our portal that about approximately half of the patients who are having difficulty quitting, or at least are coming to quit, have a psychiatric condition, most often depression and anxiety. But up to 8% could have a severe mental illness, such as schizophrenia, bipolar disorder. So, you know, the interesting thing is, even in primary care, the smokers who are coming to get help are not just your word-well healthy smokers. We actually have smokers who have quite a lot of comorbidities. So in addition to NRT, we need to talk about what other options might be there. And so today what I want to spend time talking about are three things. One is, you know, there's some more research that has come out about various studies around using Varenicline in people with mental illness and how can we approach that. And then take a look at what would be some of the better practices in helping people with tobacco addiction. And then how do you tailor your medication protocols to the client in front of you? So again, you know, when we take a look at it, we are still dealing with that. Most people consider this as a bad habit, and they should be able to quit on their own. So this is, and in fact, the research suggests that even smokers have internalized this message, and they will attribute their final quit, which may take anywhere from 7 to 30 times to be as successful as, at the end of the day, they did it on their own. What they discount is all the stuff they learned on their way and what medications they may have used before. So regardless of that, the downside of that is many smokers don't try because they believe that they have to do it by themselves. So what we have to do is make sure that when we have a client or a patient in front of us, that we help them understand that, you know, the addiction to tobacco comes from both the chemical structure of how tobacco and nicotine specifically affects the brain, that it has a direct neurological effect, and that's how it takes hold of the addiction. Right now, the neurobiology of addiction would say people start with the binge use cycle where they try it, they like it, and over time in adolescence, especially if they're genetically at risk, what they do is they'll end up beginning to want it, such that they start using it with their friends, and then they go into the next phase, which is needing it. So if they don't get it, they need it, which is what we see in our smokers who are coming for help, is that they say, you know, how soon after you wake up do you have a cigarette? And most people are saying within 5 to 10 minutes. We have some patients who wake up at night to smoke just so that they can go back to bed to manage that withdrawal. So when we're helping people quit, we have 3 phases of treatment that we're trying to help them. Is 1, manage acute withdrawal. So that's 5 to 7 days, because that's usually what's driving the smoking. In addition, what overlaps with that and persists after that acute withdrawal stage is what we would call the automatic or habitual aspects of smoking, which means it's got conditioned to all those activities in their life. Smoking has hijacked all the daily activities, whether it's getting up in the morning, drinking a cup of coffee, having a meal, having a drink, socializing, taking a break. It has become part of that learning system. And lastly, it's also co-opted the stress system, because what people recognize is that under times of extreme stress, when they are seeking comfort, they go back to cigarettes. So roughly, we are looking at helping people overcome these 3 stages to be able to achieve roughly about 100 days of abstinence, because, and I'll come to that in a bit as to why we want to do that. So what we have to help educate our patients is that the medications are not a magic bullet, but what we're trying to do is to help re-normalize these 3 neuronal systems or neural systems or circuits that have been compromised and influenced by repeated exposure to nicotine in a pulsed fashion through cigarettes. We also want to make sure that we are in the initial stages, it's managing withdrawal and controlling cravings, and ideally preventing relapse in the long term. So we know about all the various nicotine replacements, and these are the various forms. We have the patches, we have the gums, the lozenges, the inhaler, and the mouth spray available in Canada. So some of you are familiar with this. This comes from our work with Canada, which are the guidelines, and we really help you sort of walk through it to say, okay, if you go to the left side, it goes to the 5 A's in a sense, but it also gives you some branches there about how to integrate the motivational interviewing piece, and I'm going to try to see if I can show it to you. But the motivational interviewing piece here, you can start seeing that it helps your patients who are not ready, what you can do. Also, if they are ready, we ask their readiness to quit and these two questions are very quick questions to tell us where they may be. Now, most people who seek to quit will have high importance but low confidence, and that's where we can help them and assist them. So we also need to understand that those who are low, not ready or low confidence, we have to start exploring using motivation interviewing to get them to be better ready to do that. So what does the assistance look like? Cold turkey is what people call it, and we've used the colloquial term because patients say they use cold turkey. But cold turkey often in their mind means that they don't get any help, they don't use any medications, but they're actually using various techniques to be able to manage behavioral techniques, such as stimulus control, so not having cigarettes around, committing and self-talk, saying that they won't smoke. So if people are adamant and they want to do it, I say go ahead, and if you know within 3 to 4 weeks, if it hasn't worked, it's not working for them, they'll be much more ready to come and get help. So I always tell people, look, if you want to try cold turkey, go ahead, here's how you could do it, and come back and let's see how it's going for you. The second piece is you have to make a decision with them, which is whether reduction to quit or whether they're going to actually quit abruptly. And for both ways, they can use pharmacotherapy plus or minus counseling. Roughly, we say 10 or more cigarettes a day for those who need, sorry about that, who need pharmacotherapy. This is very detailed, and I won't go into it, but generally we have a choice of 3 first-line pharmacotherapies, and previously nicotine replacement had to be given due consideration before we went to Varenicline or Bupropion. Nowadays, based on current results, we could look at ways in which we might be able to better match people to these first-line therapies instead of having to do it in a stepwise way with nicotine first and then Varenicline or then Bupropion. And again, all of the medications should be tailored with individuals' needs and preferences. So, regardless of whichever medication we try, in general, we should follow people up in the first 4 weeks. Ideally, and this is because of 2 reasons. One is the highest rates of relapse occur in those first few weeks. And in fact, 80% of people have relapsed within that, first 3 months. And generally, about 60% have done it in that first month. So we do need to follow up people early rather than sending them on their way, because often they struggle, and in fact that's often a reason why they stop their medications, because they believe it's not working. So if there's a way to do follow-up, it doesn't have to be an in-office visit. It can be done by phone, of course, unless they're coming up to pick up NRT or something. But other than that, it can be done by phone. What we're really assessing in that follow-up visit is, are they responding? Are they having a partial response or a full response? And if they have a full response, then continue to help them on their way and start working on relapse prevention. On the other hand, if they have a partial response, assess if they're actually taking the medication as prescribed. They may need a dose adjustment because we may have started them on a too low a dose, and we may need to increase the counseling required because they may be, for example, not smoking, may have a household member who smokes around them and gives them easy access to cigarettes. We have 2 choices to modify the pharmacotherapy. One is switch to a different line of first-line medication, so we could just go back. If we had started with one, go to the next one. Or we could go to combination therapy. And Bupropion with Varenicline, Bupropion with nicotine replacement, 2 forms of NRT. And there are currently some studies that suggest that, and one Cochrane analysis that suggests that Varenicline plus NRT could work well as in addition to just Varenicline or NRT alone. In the algorithm that we use in our in Teach and Stop, we basically divide people into light, moderate, or heavy smokers. And if you look at the literature, that term heavy smokers can go anywhere from 10 cigarettes or more to 15 cigarettes or more. We've actually done this light, moderate, or heavy primarily because you could help guide you to decide what strength of patches you might need. And again, just yesterday I saw a patient who was actually smoking closer to 20 cigarettes a day, and the provider had given them 28 milligrams, and that was too much for them. So I always say, you err on the side of giving slightly lower, but you can always go up. But it's hard to give them something that is, you're trying to match how much they're smoking and give them excess medication, and then they'll end up with a side effect. So, and combination therapy of nicotine replacements works better than monotherapy. So obviously it's one short-acting for breakthrough cravings as needed in addition to the patches. We follow them up and again look at what needs to be added and how, this is how we titrate up the additional patches if the person is still smoking. So if they're smoking 10 or more cigarettes, we'll add another 21 milligram patch. If they're 6 to 9, we'll stay with the 14, and if it's 1 to 5, we'll add a 7 milligram. And we may choose a short-acting or in addition to that, and again reassess them in 1 to 4 weeks. And this is again off-label of how we do it. Again, this is, you won't find this in the label, but this is titrating to the effect of people who are heavily dependent smokers. And what we try to do is get them to a maximum of 84, not in every patient, but for those. So maybe I'll have maybe a handful in a year, maybe 5 patients who need this amount of NRT at most. For most, you can manage with an average of 56 milligrams. For the heavily dependent smokers, that's for this group who are smoking 30 or more cigarettes a day, usually have a mental illness, usually in living in a group home, often have a long-standing history of tobacco use disorder, and are extremely heavy smokers. So in so it's not not everybody has to go to 84. I want to make sure nobody walks away with that message. It is what we talk about. This is titrating to the effect that the person needs. Now, when is a person ready to reduce? We ask them to reduce by about 7 milligrams every 1 to 2 weeks until they're off, and then we'll reduce the short-acting until it's no longer needed. And more often than not, they're using the short-acting really as a safety valve in case they end up having cravings. For the most part, we find that our patients are quite comfortable with this model, but you do need to monitor them. Combination treatment. So again, as we said, we increase the amount of NRT, or you can combine with long-acting with the short-acting, and usually we pick one. Then the other medication we have, which is again evidence-based and is allowed to be used, is Bupropion, and as this icon shows, it essentially helps 1 out of every 3 smokers. It doubles the success rate in helping people quit, and it roughly helps 1 in 7 smokers treated for the 12 weeks. What we noticed is that patients will report it reduces the pleasurable effects of their cigarettes. They don't have as much withdrawal. They say they can go much longer without a cigarette, and when they quit, they don't feel so low. Very importantly is that out of all the medications, it minimizes the post-cessation weight gain. Unfortunately, the weight can come back when they once they stop the medication. And on that algorithm, if I just go back to it, I can show you. Over here, we put it in bright pink, quitting smoking and weight. 405 people will gain an average 4 to 10 pounds, up to 30 pounds. And more cigarette smoke, more weight gain when they quit. But Bupropion delays that, and so does the gum and lozenge. So we pay attention in our program around managing weight and appetite, especially when people are quitting, because as we know, that weight gain could essentially tip somebody over into insulin resistance or glucose intolerance, and we don't want to get people getting better from quitting smoking, but then developing a complication like diabetes. So we pay great attention to that, and I think Bupropion has a great role to play. The contraindications, as you know, is seizures, people taking Bupropion for depression, also known as Wellbutrin, and individuals with an active eating disorder, and individuals taking an MAOI inhibitor. So again, with the Bupropion, one of the key issues here, and I'll come to it later, it's the cheapest smoking cessation medication on the market right now if you get the generic. We're just talking about it in Alberta, for example. 90 days of Bupropion generic for the full course of smoking cessation is only $50. So, and if people are buying cigarettes that are for $8 a day, roughly 1 week's worth of smoking cessation of smokes will be what they will be will cover 3 months of Bupropion. So Varenicline, again, is the most effective medication on the market right now. It triples the success rate. It attaches itself to the nicotinic receptors in the brain and is a partial agonist, which means it doesn't fully activate it like nicotine does, but enough to block the receptor and keep the person out of withdrawal. And should people smoke on it, what they will report to you is that the cigarette stays flat or they don't enjoy them anymore, they can't finish their cigarettes. They'll also tell you that they're not in withdrawal as much, and certainly it reduces the cravings over time. Clearly, the contraindications are individuals with serious hypersensitivity. And most of us, if we ask, when would you not prescribe this medication, will say the following. We are worried that it's going to make you, I've heard that it's going to make you crazy, or it can cause you to get worse and make you depressed, it'll make you psychotic, make you suicidal, it'll make you, homicidal, etc. And as a result, because of these case reports, many healthcare professionals have been reluctant to prescribe these medications, and primarily it's Bupropion and Varenicline, especially to those who have diagnosed psychiatric disorders. But here's the problem. We have tobacco use, which is more than double the prevalence in those with psychiatric populations. So this patient population is bearing the brunt of the tobacco epidemic as we speak. Moreover, the FDA put a black box warning initially on Varenicline because they said it could cause people to get depressed, suicidal ideation, and completed suicides. And more importantly, that it decreases people's tolerance to alcohol, it causes them to be aggressive, especially if they consumed alcohol and had Varenicline at the same time, and 64 cases of seizures in those who had used Varenicline, and 58% of these had no history of seizures. So all these case reports cause this black box warning and caused us as prescribers to get a bit anxious about doing that. So the FDA went back to Pfizer, who is the manufacturer of the drug, and said, you need to do a study designed by us in which you have input from us to be able to say which drug is the safest in those with and without psychiatric disorders. And therefore, this is the EAGLE study, and it was recently published in 2016. And here's what it is. It's a very complicated study, and I'm going to walk you through it just to make it easy to understand and understand the limitations. So roughly more than 8,000 participants across all the countries, all the continents, I think, 18 to 75 years of age, men and women. Approximately half had a current or past psychiatric disorder, and about half did not have any. What are the interventions? People who are randomized in a blinded fashion to either getting placebo, and the placebo was either a placebo patch or placebo pills, nicotine patch, Bupropion, or Varenicline in standard doses. So everybody was getting some sort of patch, either a placebo active patch, and or Bupropion and or Varenicline. So at the end of the study, basically there was no significant increase in these neuropsychiatric effects that could be attributable to Varenicline or Bupropion relative to the patch or placebo. And there was no difference in the incidence of neuropsychiatric adverse events among the 4 treatment groups. So what is this? So this study, which is highly powered, that means it should have been able to detect this difference, failed to detect a difference between the two, between the groups, which meant if, statistically, any kinds of side effects, neuropsychiatric, that we might be seeing could be primarily due to nicotine withdrawal per se, not the drug itself. Now, on the other hand, there were more reports of neuropsychiatric adverse events in the psychiatric cohort compared with the non-psychiatric cohort, so 238 compared to 84. And again, when you look at these effects, remember, most of the people with the psychiatric disorders had depression and anxiety. People with schizophrenia had to be very stable. People with other addictions had to be stable. So again, these results do not apply to those with unstable mental illness. So the issue is that right now, based on the best scientific evidence, we should consider people's psychiatric stability. And if they are psychiatrically stable, for the last 6 months they haven't had a dose change, they're functioning as outpatients, they're doing well, they're under good care, their mental status is good, we should feel confident prescribing either bupropion or Varenicline to them if they are not responding to NRT. And again, in some situations, you may jump straight away to one of those medications. Primarily, for example, in one of my patients, he has psychiatric illness. He has all these problems, but he's also got COPD. He's just been released from hospital. He's also depressed. And we skipped NRT. We went straight to that because the urgency was that he would get intubated again if he didn't quit. However, we just don't give it willy-nilly. We do need to make sure that we do an assessment of our client. So we'll do things like in the STOP program, as you noted, there's the PHQ-9, so you could do that. Or you could just do any kind of simple assessment of people's mental status. In addition to the PSQ-9, screen for suicidality and risk of suicidality, document it, and advise and educate the patient to be in touch should their mood or their psychiatric well-being change while starting this medication. And we just need to monitor them, which goes back to that reason to monitor people in those first 4 weeks of quitting. It's not good practice to give people a prescription of Varenicline and say, come back in a month, without warning them that if they should have mood changes or psychiatric changes, that they need to stop the medication, call you, and again, go to the emergency room if it's so warranted. So, again, how do you prescribe this? If you do decide to prescribe Varenicline to a patient, what are some of the contextual issues that we need to think about? So clearly, advise patients that if they're drinking alcohol, and again, in the STOP protocol, you can see that there's the audit score, so you can get a number of drinks that people are drinking. If they're drinking occasionally, or they're drinking and also not drinking to excess, so not binging more than 5 drinks in any given situation for men or 4 for women, and they never had a problem with alcohol, advise them that they might find that they lose their tolerance to drinking and should therefore not drink and get behind the wheel of a car. They shouldn't do that anyway, but more so. Again, weigh the risks and benefits of seizures in a client with a history of seizures or factors that can lower the seizure threshold. And again, I've never seen this in any of my patients, but again, it is one of the recommendations. As we said, obviously discontinue Varenicline if you have experienced a seizure or any of the side effects. And again, stop it immediately if they get aggressive, depressed mood, for example. Always encourage our patients to read the medication guide. Not everybody is literate, so you may actually sometimes have to walk them through it. And again, and the FDA suggests that we report it to the FDA MedWatch program, but in Health Canada also has a reporting system, and I strongly suggest that you report if you have a patient who has an adverse event. So let's take a look at the costs. So decisions to use a medication obviously are the indications, so the medical indications. And clearly from an efficacy perspective, Varenicline is way better than bupropion and is equivalent to combination nicotine replacement. It has many advantages in terms of ease of taking. It's a pill. You continue to smoke while taking it for the first few weeks. And you can get an effect of getting people to quit even after the first 4 weeks, which you don't see with bupropion and nicotine replacement. So it's a fairly good drug, and it should be used, but again, as we know, it's not being used as much as it could be. The second thing is that when you take a look at the cost, which also factors into people's decisions, especially if they don't have coverage through ODB. Now, if you're on ODB, obviously we're in Ontario Drug Benefit, for those of you from outside of the province will cover once per calendar year Varenicline or bupropion, not 2 together, for 12 weeks. However, people are buying, these are what the costs are for people. And again, as I was telling you, the cheapest is bupropion. It's the most inexpensive smoking cessation treatment on the market right now that has a proven benefit. So those are how we would initiate and monitor benefits, and we at every visit monitor for adherence, side effects. Now the question becomes, how do I know when my client is ready to stop medication? Should it be time-based? So you've been on it for 12 weeks, or you've been on it for 6 weeks, or you've been on it for a particular period of time. Should it be time-dependent, or should we actually have a much more sophisticated way of understanding every patient and make it patient-centered based on the best available evidence? So, as you know, standard duration of treatment is 10 weeks. And then in the last 4 weeks, you taper down to 14 milligrams for 2 weeks and 7 milligrams for 2 weeks and stop. There is no scientific basis for this, and I have had many patients who just stop their nicotine replacement without any withdrawal, no problems. Varenicline and Bupropion brings that abrupt stop, which is 12 weeks of treatment and then stop. We also know Varenicline can be taken up to 24 weeks if necessary, and again, it's indicated for people who've been abstinent for their last 12 weeks of Varenicline who are not ready to stop Varenicline yet and can take an additional 24 weeks, and you see a difference in the quit rate. So what do we look at? What I look at in my clinic is, has the person been able to achieve 100 days of continuous abstinence? Why 100 days? Because there's research to suggest that most of the relapse that's going to occur is going to happen before 100 days, and that those who achieve 100 days of continuous abstinence, less than 5% will relapse after that time. So it's not zero, but if people can make that 100 days, and so what I've found with patients, giving them milestones along the quitting journey is roughly like this, and it seems to resonate. So first is obviously coming to a quit date, and so that's the part which we talk about, the strategy part of the stop, like you're creating a plan to get to that quit date. And then going 24 hours tobacco-free is one milestone. The next milestone that I try to get my patients to achieve is at least 7 continuous days, and that's an important milestone because we know that, again, that's associated with long-term quitting, and then we try to get them to get 30 days of abstinence and then the 100 days. All of these are linked with each other, but there are milestones along the way and can help people break it up. And that's where we talk about the stop part, which is the S, which is the strategy to get to that 1 day. The T is the take action, so that's that quit date. The O is the optimization, where they're trying to get the 7 days and the 30 days. And you know they've done that is when they reach that 100 days, and then the P is the prevent relapse, because beyond that 100 days, that's where they're going to need that help. Usually it's managing stressors and committing to that not just one puff. So again, when I'm asking people, again, these are competencies for people to achieve, I ask them, how well do they cope in a stressful situation, which otherwise would make them smoke in the past, and they don't, and they haven't? How are they responding to triggers and cravings in the environment? Are they having near misses? Are they having slips here and there? And if they haven't, then they're ready to come off. If they've been through all that, then they're ready. If not, they often are coming off prematurely, because then when they come into the situation, they don't know what to do. So this is a much more a different way of moving and combining a time-based, that's the 100 days, with certain key milestones and competencies. Are you able to resist smoking in these situations? Under stress, when you're exposed to the triggers that made you smoke in the past, such as alcohol or workload or taking a break or coffee or a meal or bowels or whatever it might be. Are you able not to have a smoke? And are you having cravings? Because those are all indicators that this person is going to go back. So that's how we titrate up medications and decide when they want to go. So now coming back to the earlier questions, which is how do we know when the medications are no longer working and what should we do about it? So obviously, first things first, are they adherent to the treatment program? Many patients believe, I no longer need to take the medication because now I've quit and it's only been a day or 2 days or a week. So that's one thing, and really that most people are not completing their course of treatment. In the real world, only about people on average only take 2 weeks of NRT. In the STOP program, what we see is that people are actually completing on average 12 weeks, and that is essentially what is associated with sustained quitting. So trying to get people to complete their treatment is the key piece. Bupropion is about 2 to 4 weeks, and Varenicline again is 4 to 6 weeks, and what we need to do is get people to commit to taking all the medications to the end of treatment. And so often what I have to work with patients is getting them to think about the medication is like a cast around a fractured bone. you cannot take it off too soon, even if the pain subsides. You need to let the brain heal, or the bone heal, in that metaphor. And so people get it, that they have to commit to this, even if they're not smoking, that what they need is to give that brain time to actually not relapse and to recover. So that's one of my sort of conversation with my patients is medication adherence, compliance, whatever language you want to use about it. The second thing is, are we giving them enough of the medication? Are they taking enough? Especially when it comes to nicotine replacement, this is not so true with Bupropion or Varenicline. Is the dose too low based on the number of cigarettes per day? So it's just what we are giving them, is it too low, and therefore we titrate up, as I mentioned before. On the other hand, other things that we need to know about is what has happened to the clients. Are they smoking exactly the same amount, no change, or they've actually reduced, and they're just having slips here and there, or they're responding to certain triggers because there's somebody at home who's smoking? What's causing them to have these triggers? Is it because they are really going into withdrawal, which gives you an indication that the medication may not be strong enough, or are there triggers that are happening? And so our questions to patients are, when you do smoke with your medication, what's that experience like for you? And if patients tell me that, oh, I had a cigarette because I was with my friend Bob, and Bob was smoking, and he offered me, and I took a drag, but I wasn't able to finish the cigarette. It tasted horrible. Then that's what we have to help people understand, that, okay, so right now you still have to work on the behavioral aspect. The medication dose is correct, but you have to work with responding to triggers and cravings. And so that's much more for behavioral intervention. On the other hand, the person says, I had the patch on, I was craving a lot, and I couldn't just get cigarettes out of my mind. I had a cigarette, and then for at least half an hour I wasn't thinking about it anymore. Starts telling us that the patches may not be strong enough. Especially the person says, I didn't get a headache, I didn't get nauseous, I could finish the cigarette, I didn't go into any signs and symptoms of toxicity from the nicotine, from the cigarettes, then you're not giving them adequate nicotine replacement. So that's how we assess what to do, and then accordingly either switch the medication, add medication, and or add a behavioral component to it. So now that was cigarettes. Now moving on to smokeless tobacco. Not all of you deal with people who use smokeless tobacco, but this is chewing tobacco that comes in a tin usually. And it's called, and these come from our colleagues from the Mayo Clinic who tend to see people with, who tend to use a lot more chew tobacco. And in Ontario, you'll see it much more in rural communities, youth maybe, and as you go further north, you have much more oral tobacco use. So how do you help people quit oral tobacco when using pharmacotherapy? Here's how some of the classifications. So they're using 3 cans of snuff or 3 pouches of tobacco per week. They're heavy users. Those who use 2 to 3 cans are moderate, and less than 2 are light. NRT has been effective, but dosing considerations have to be taken into account because people can get much higher levels of absorbed nicotine from oral tobacco depending on how they use it. And so nicotine often can be inadequate to help them. It's unclear about Bupropion's role, and Varenicline certainly has been found to help people, those using smokeless tobacco, and using them again with, in standard doses. So again, on our FAQs, we have information for you about dosing for those who roll their own cigarettes, how to start. In general, the principle is you start low, start with short-acting, see how much they need, and then switch them to long-acting patches depending on how much they're using. If they're using other tobacco products like hookahs and others, all bets are off. And again, what I often tell people to do is use short-actings if you're trying to use nicotine replacement. You don't have to worry so much if you're using Bupropion or Varenicline. As we said, ODB covers one cost of treatment, and it's not specific for cigarette smokers, so you could use it in this population. For those of you using alternative nicotine delivery devices or in combination for NRT, that's also on us, and ENDS are also known as e-cigarettes. That is a changing role, and we're not really sure what to do right now. It's a case-by-case basis, and clearly you'll see what we do with people who are using that in the FAQs. What I do is actually because I'm not sure what the quality of nicotine is from batch to batch, I will often use a short-acting initially, maybe a middle dose patch to start with, especially if they're exclusive e-cigarette users and want to stop using it. The biggest challenge is that what I've had with the e-cigarette users that I've helped is that many of them tend to be grazers, which means they are puffing on their e-cigarette through the day, especially if they have the ability to vape indoors. And now, so that's what they're doing, and then they get various strengths of nicotine, and they're trying to taper down using that. Given that I cannot comment on the whether that, if it says 18 milligrams per mil on the bottle is actually 18 milligrams or less, I have no way of knowing. But we do tell people to start tapering and moving over to non-nicotine containing e-juice from as much as possible a reputable supplier, and avoid things that have diacetyl and which is the butter flavor or popcorn flavor. Avoid those that have cherry and avoid those that have cinnamon. And then just because of some of the published reports about potentially them having problems with that. So you could take a look at those for more details. Again, that's an evolution. And then again, looking at what do you do when people are using marijuana and using tobacco and blunts, for example. And as you know, often when people have withdrawal, when they're stopping marijuana, you have to make sure it's not actually nicotine withdrawal that they're experiencing. And so separating the act of smoking from the consumption is one strategy that we talk about in those not ready to quit marijuana use, but are ready to quit tobacco use. So now we're going to time for questions. And so in summary, what I'm going to say is pharmacotherapy is evidence-based, but there's an art to adapting it to the patient in front of us. Clearly, if people are not responding to standard treatments, you've given them NRT in the STOP program, they are coming back a week later or 4 weeks later, you maximize their dose of NRT and they're still smoking, do consider, if feasible, whether they should get Bupropion or Varenicline or both. And again, you do need just follow those directions. We're quite happy to share them with you, as you know, through the slides, with your prescribers, if there are any on the call, and help the patient quit smoking, because if they're showing up, definitely do that. Okay, so let me go back to the questions, and I'm going to scroll up to them to see what questions we had.
So, Peter, I've scrolled up to the top. The first question is from Cheryl. Could you comment on people using electronic devices to quit? Is there or will there be pharmacotherapy guidelines specific to vapor products? I know this is difficult as the amounts of nicotine in these devices are still a guessing game.
Yeah, I think so. That's exactly right. So just because the federal government has come out with a modification of the act where they are going to follow up and have electronic cigarettes with and without nicotine available on the market for adult smokers. As long as they are not making a claim for quitting claim and a health benefit claim, they can sell them over the counter. If they want to make a health claim, they will have to submit to Health Canada, much like any other manufacturer of medication. So stay tuned, and I think we will see some products in both categories. And once that is done, we will need to make sure that we have the right research to help guide us if we are the ones recommending these medications. So what I would say is stay tuned.
And the second question is with respect to the NRT algorithm that you discussed. I could flip back to it. So some people were saying that the guidelines for light smokers was different. Their version has 14 milligram patches. So I've uploaded the updated one, but I just wanted to know if you wanted to comment on that.
So let me see the updated one. Are you going to put it up?
Yeah, just trying to find the slide.
It should be one after
Here it is.
that. Okay, so what the question is, can you comment on the discrepancy between your recommended approach to light smokers, less than 10 cigarettes a day, versus the November 26th NRT algorithm sent out by STOP that recommends NRT patch 14? So first of all, take a look at what we mean by light. if that has been sent on, I'm going to make sure we correct that, because in general, we're trying to get away from using patches in those smoking 10 or less a day unless they're absolutely sure, that they can tolerate that 7 milligram or 14 milligram patch. So leave that with us. We will clarify and send out the right one. To me, so far, this has been what I've been using and seems to make more sense. But Rita, let's make sure we get the right one to you.
Okay. So the correct one is here for download, right over here. If you click tobacco algorithm, the first 2 pages is the algorithm that Dr. Selby discussed in detail earlier, and then the 3rd page is this nicotine replacement therapy algorithm. So be sure to download it. So
something was sent out November 26th. So let's just make sure the November 26th one and this one align. So before you download that, Tanya, can we just check with Ryan to make sure we are sending the exact same document?
Sure, for sure.
Okay, so maybe just pull that off right now. Don't let people download it.
Okay.
To clarify. Sorry about that. Okay, next.
If they want to choose a reduction to quit, is there a recommended time frame to set a complete quit date?
Ideally, a reduction to quit should be done within, 3 months. They should have reduced by about 50% and continue that till about 6 months where they're no longer smoking. And again, with the reduction to quit, you have to be careful about what's known as compensatory smoking. So people may reduce the number of cigarettes, but are actually, more efficient with each cigarette. So when we see a reduction to quit without pharmacotherapy, we often notice that the people are actually being more efficient per cigarette. There's no actual health benefit from a reduced exposure because every cigarette does you harm. In fact, just yesterday, a paper came out talking about long-term exposure to approximately 1 cigarette per day, and you can detect an effect, a negative effect, and significant negative effect. So in the short term, behaviorally, it's a very positive step that they're actually reducing, they're softening their addiction, they're trying to do something. So we go play it by ear, but roughly you should see people reducing by about 50%. And what they're going to be successful if they've committed to monitoring their smoking, they're actually writing it down, they're actually having a target, intermediate target. So today they're smoking 20, tomorrow they're smoking 19, the day after they're smoking 18, they're measuring their cigarettes, they're not keeping that's a successful reduction to quit because they're putting in the cognitive effort to do that. Yes, we have the reference for the 100-day smoking cessation. We will send that out to you. So that's a question. And any other questions?
Yes, there's one here. I remember you saying that if the patient is on NRT longer, they are more successful with staying abstinent. Can you comment on that?
Yes. So in the study done here through OTRU and others have shown that minimum 8 weeks is effective. So people who stay on it for longer than 8 weeks seems to have an effect. In the stop on the road, when we're comparing 5 weeks to 10 weeks, what is fascinating is when people complete all their treatment, regardless of which group they are, they're more likely to do better than either group, if they don't take all their meds. So there's something about people who cooperate with the treatment plan that when they are committed and complete their treatment, it works better. Now, we've also checked the other way around. It could be that people who are successful are more likely to keep with the treatment. And in part that might be true, but even after we control for that, you still see an effect. When people take their medications, it works better. So longer the better. And again, at minimum 8 weeks, and again, committing to not taking that puff and staying abstinent, again, are all factors that go towards being successful. Our biggest problem is people get nicotine replacement standard doses, smoke on it, then think the patches are not working, and abandon it, versus us starting the patient off and then titrating it up to the effect that they need. So that's part of that conversation. If you do smoke with your patches on, come back and talk to us about dose adjustments.
The next question here is from Colette. The maximum for the inhaler is 12 per day. I work with a client who indicates they require 17 to 20 cartridges per day. Is it recommended to go beyond 12?
So what I notice is that, again, if people are just using it as monotherapy and they're heavily dependent smokers, they often do need more. And so as long as they can tolerate not having side effects, they're not getting hiccups, they are using it appropriately, they're helping them stay abstinent, then it's fine. Of course, they're going to run out of it much faster. But in those situations, I often offer them a combination, so patch plus inhaler, and they'll start noticing that. Now, a reduction in need for inhaler because they're trying to get all the nicotine from the inhaler. So here's my concern. My concern is that they'll end up using the inhaler long term and may have difficulty stopping that. So I try to make sure that they're not getting this contingent exposure to nicotine, which means when they have a craving, they're using. Kind of give them that steady dose through the patch. So that's my preference. But if there's a patient here and there who wants to just use monotherapy with the inhaler alone, I'm okay with that, even if they're using higher than recommended maximum doses, as long as they're showing up, their CO monitor is showing that they're smoking, they're in the non-smoking range, they're doing well. It's okay to go above that, as long as they can tolerate it.
Okay. Lita's asking if you can list the different flavors of the ends to avoid. I remember butter, popcorn, cinnamon. I'm going to type them out.
Yeah, so I think if it has that acetyl, avoid that. And that's that butter flavor. And cinnamon and cherry.
Cherry.
Okay.
Right. The next question is, what about NRT for pregnant and pediatric patients?
Okay. So let's go with pregnant women. All the trials with pregnant women have been negative trials because we have not been able to actually, when you study nicotine replacement in pregnant women, it's very difficult to randomize control trials. And so many of the trials that have been done have been negative. But what you do notice is a reduction and an increase in birth weight of the infant. If you go to our pregnant site, you will see the algorithm there, and you'll also see how we approach it. So, as you know, most pregnancies are unplanned but not necessarily unwanted. So many people don't know that they're pregnant in that first trimester. Some experts have suggested that we give women nicotine replacement in the first trimester, but pragmatically, there's no way of knowing. There's another reason why I don't like to give nicotine replacement in the first trimester is because in all pregnancies, smokers or not, 25%, 1 in 4 pregnancies will end in a miscarriage. In smokers, it may be 1 in 3. So here's the downside. If somebody is pregnant, they're smoking, they want to use medication to quit, and they quit, and then they miscarry, they're going to say, it was a nicotine replacement that did it, not the natural history. So roughly what we try to do is help women use behavior. And the other thing that happens in the first trimester is because of morning sickness and other factors, most pregnant women will stop. And about 5% will continue into the second trimester. So that's the group where you want to have a behavioral intervention. They're unable to stop. That's when you give, intermittent doses of nicotine replacement, the lowest effective dose, not the least effective dose. What that means, doses that are enough to help us stay tobacco-free. So that's how we would use nicotine replacement. You can also use it in pregnancy, in lactation. And again, the suggested evidence would suggest that you would take the nicotine replacement just after breastfeeding is completed. In the pediatric age group, it depends on how young. And again, you have to see can you confirm that this child or this patient is actually nicotine dependent. Don't only rely on self-report because it's not very reliable, and you need to make sure you have some corroboration that this person is dependent. The second part is usually now, especially in developed countries where smoking has prevalences are dipping down between 15 to 20%, young smokers are much more likely to have comorbidities, whether it's ADHD or depression or anxiety. And so rule out those other conditions and treat those other conditions as well as the tobacco addiction simultaneously. Using nicotine replacement may be appropriate, but often you're using things like bupropion in that population. So I would say the pediatrician or the adolescent medicine physician or the child psychiatrist needs to pay attention to what's going on with this young person and then use medication. If there are no comorbidities, definitely try quitting on their own. There is no reason why people shouldn't give that a go using behavioral mechanisms alone.
Okay. So the next question is, do you have a suggestion with regards to the to advising patients that they stop smoking once starting NRT? I remember you saying once that they could smoke as usual for 1 to 2 weeks of starting the patch, similar to Champex, but plan to be quit at 2 weeks. Is that reasonable to suggest?
So I think, here's the issue. In colleagues who are dealing with high utilizers in the healthcare system, they tend to be women, elderly, and in Ontario as well, elderly women with COPD who smoke and are lonely. And I think really we have to take this biopsychosocial EBB approach where modifying the environment is going to be as much as an important factor as is pharmacotherapy, and working on activities, because if somebody has no interest in quitting, lives alone, has lots of time on hand to smoke, what are some of the activities this person can do? One of the other things, especially if you have a health promotion worker or a social worker or somebody who can work with patients who have difficulty like this, cigarettes have often been personified into their best friend. And helping them give up their best friend requires a little bit of grief counseling, really, or helping them break up. And I found that is a very effective way to help many of my patients who smoke break up with their cigarettes, because it's really the thing that has been with them during thick and thin, when they're alone, when they're angry, and it goes beyond just the nicotine replacement. They have this attachment that they have to be willing to give up. So we're often talking about that, talking about being busy, talking about helping them get active as much as is possible. So often that becomes the issue in this situation. We often allow for concurrent smoking with nicotine replacement as a way to help that break up. But again, understanding that we take a biopsychosocial approach to patients like this. Is nicotine spray a concern for recovering alcoholics? Yes, it is a concern. There is a certain amount of alcohol, probably about, we've discovered a whole, if you spray the entire can all at once, you'll probably get the equivalent of half a drink. So I use some caution in people who are, especially if they're taking antabuse. If they're not, for the most part, there's not enough to prime them, but again, it's anybody's guess. I take a look at how much, at how stable the alcohol use disorder is, and then decide whether mouth spray is going to be used or not.
Gary asks, I know of one individual who has multiple mental health diagnoses, has been on ODSP for many years, and is a chronic smoker. She lives alone, has lots of time on her hands to smoke, and has COPD.
So that's the one I answered.
Oh, sorry. Okay.
So I think you're going to Anita's. I'm going to Anita Singmar's, which is quitting smoking for 9 months.
9 months, yeah. Smoked for
How many doses is she allowed to use? Last month she was using up to 15 a day. So when we've had people who are this long-acting, I go back to what is it that they're looking for. Remember, smoking has a pharmacological effect, and then it has a sensory effect, and it has a motor effect. So that hand-mouth, the sensation. So when I'm asking, when they're using this nicotine in the mouth, what are they trying to get at? Are they trying to manage pharmacological withdrawal, in which case really the patches make the most sense, or switching to bupropion or something like that? If they're after for the oral sensation, then we are looking at substituting with non-nicotine substances as they're tapering down their lozenge, and usually whether it's gum or something else to keep their mouth busy is important. And of course, for the motor, that's where the inhaler comes in, but are there other things that they need to do with their hands to help them with that? So I break it apart and really look at helping them come off. The ethical dilemma is that if they've quit smoking, are they declaring to us that they need nicotine for some reason? And are they getting it in the safest way, which is the lozenge or the gum? The gum, of course, has a problem with TMJ and chewing and dentures, but the lozenge, in and of itself, probably doesn't have too much if they are actually rinsing them out after, etc., because that way they're getting rid of the acidity that it causes. One of the things people forget is that with lozenges and gum and the inhaler, the person should not have used any coffee, juice, etc. 15 minutes before and 15 minutes after, because the nicotine has to get absorbed through the buccal mucosa. The question you have to ask the patient is, if this person is having lozenges with coffee, they may not be getting 15 lozenges worth of nicotine delivered. They may be only getting half that much or none of it. So really working with this person to understand and unpack what that use of lozenge means to them is important. Yeah, the flavors are with the electronic, the e-juice. So that's what Bridget asked. I'm just going to go through all of them through here, but I need to make sure it's 1 o'clock now. So I'm going to actually conclude and again say that the webinar is available for those who missed it. And the spray is coming to the stop soon. So will it have a higher risk of addiction than the gum or lozenge? Not that we've observed or not that it has been reported. But anyway, I want to thank everybody. Please complete your evaluations and continue your questions to us, and we will continue to answer them for you.
Perfect. Thank you. So again, as Dr. Selby said, please be sure to complete the evaluation, which I posted into the chat. I will be sending it out via email as well. If you've completed the registration and pre-learning assessment, you'll also receive the link to the post-learning assessment, and all of this will be emailed out by 4 p.m. today. And if you participated as a group, please be sure to email teach@camh.ca with a list of attendees. The next session will be on January 25th, also a Wednesday, from 12 to 1 p.m. Eastern Standard Time. Complex Client Journey, Part 1, and you'll be able to submit a case that you're working on, a complex case for this webinar. And if you missed the beginning of today's presentation, want to view it again, or you want to see previous webinars, not a problem. They are all archived on our website at the link at the bottom there. And thank you, everyone, for attending today. We hope you enjoyed it, and we'll see you at the next one. Take care.
Happy holidays, everybody, and thank you, Tanya, for all the help you've given us over the years.
Yes, thank you.
Thank you.